So, hello everyone, good afternoon. I'm Dr. George Castellanos. I'm one of the interventional cardiologists here at Hoag. Thank you for coming. So today what I actually wanted to talk to you about is this new area in cardiology called structural heart disease. I've talked about portions of this before. But basically the way to think about it is it's a way in which you can do things to the heart that used to be done surgically less invasively, right? And typically it's aortic valve repairs, it's valvular repairs or valvular replacements, it's closing holes that shouldn't be there, it's occluding appendages, and so forth. So the three that I'm going to talk to you about today is predominantly these three, the TAVRs, TMVRs, and the left atrial appendage occlusion devices. So three different acronyms that are used in order to describe what used to be done surgically that now can be done percutaneously and less invasively. Other examples of structural heart disease are PFO and ASD closures, VSD closures, balloon aortic valvuloplasties, mitral valvuloplasties, and alcohol septal ablations. So I'm trained in doing all these. We've actually done all of them except these two here at Hoag. So we'll be talking about TAVR, a little bit about what it is, a little bit about the trials that are out there, Mitral Clip as well, indications and some examples, and then about the Watchman indication, some outcome data and examples. So the idea behind this is to give you a sense of what these therapies are, why they're beneficial, and what data supports that they're beneficial, and what's available for your patients. So the transcatheter aortic valve replacement. When we think about aortic stenosis, there's a spectrum of congenital abnormalities, so bicuspid, unicuspid valves. You can have age-related calcific aortic stenosis. As everyone gets older, you're going to develop aortic stenosis. And then the middle here is associated with rheumatic fever. In the US, typically we don't see a lot of rheumatic fever aortic stenosis. That tends to be more present in immigrants. The vast majority of the TAVRs that we do are actually of the tri-leaflet calcific aortic stenosis from age. What we do know, this is from trial data, is that if you take a patient with severe aortic stenosis and you manage them medically, or you manage them with the balloon aortic valvuloplasty, their mortality rate is actually extremely high. At 1 year, about 50% will die, and at 5 years, 93% of these patients will die. Typically, it's going to be from heart failure from the aortic stenosis. We also know that once patients develop severe symptomatic aortic stenosis, as depicted here, they decline rather quickly and they die. Typically, patients can have severe aortic stenosis for months to maybe even years, but once they hit this precipice, it's important for us to act quickly and fix the valve, irrespective of the approach, whether it's through a transcatheter aortic valve replacement or a surgical aortic valve replacement. So the first TAVR valve was done in 2002 by Dr. Crebier in France. Nowadays, these are just a sample of the different types of TAVR valves that are available. These are all available in Germany. In the United States, only this valve, which is the Edwards Sapien valve, and this valve here, which is the Medtronic Evolute valve, are available. This valve is no longer, the company actually is bankrupt. This valve here, this is called the Salis direct flow valve. This is the Lotus, done by Boston Scientific. This valve is going to become commercially available soon, and so forth. But you can see there's a lot of interest in this field in developing these valves. So a little bit about what is available for us today and what we do here at Hoag. There's the Evolute R, which is a self-expanding valve, and the Sapien 3, which is a balloon expandable valve. And the indications for these valves vary slightly. For Medtronic Evolute R, it's appropriate in patients who are considered to be inoperable or high surgical risk candidates. For the Sapien 3 valve, it's inoperable, high risk, and intermediate risk. Hoag has been fortunate enough that we're actually part of a trial called Partner 3, which is now allowing us to place these valves in low surgical risk patients. So I'm one of the co-principal investigators for this study. So now at Hoag, we're actually pretty much able to place a valve in most any patient who has aortic stenosis, severe symptomatic aortic stenosis. How do we use these valves? Well, you approach it through a less invasive access routes. You can do a transfemoral, transapical, transaortic, or left subclavian. Typically, the transfemoral is a preferred method. The data that's out there shows that those patients that have a TAVR done this way actually have less mortality than if they're done through the other ways. So transfemoral is preferred. If that doesn't work, we like to do a left subclavian approach. There isn't as much data supporting the safety of that, but anecdotally, it seems to actually work pretty well. Transaortic and transapical are good options, but there is data showing that the transapical is not as safe as a transfemoral approach. Now, 2 years ago, most of our patients were done transapically. Now they're mostly done through a transfemoral approach. And it's done percutaneously without the need of a surgical cut down. Our patients, for the most part, now leave the next day. They go home the next day. The valve has evolved over several years. It went from a very large sheath at 22 to a 24 French. Now it's a 14 and 16 French sheath. And right now, pretty much all we use is SAPIEN 3 valves. Right? And like I said, this is a particular company, the Edwards valve. I'll show you some data with the other company from Medtronic. So this is an example of us deploying this valve. So you have the aortic root shot. We have the balloon is placed here initially, and the balloon is just to make room within the valve. We rapid pace to make sure that everything is stable. We have the valve. We deploy the valve, and as the valve gets deployed, it's in the right position. That's just an example, right? So these are the hemodynamics that we can see in these cases. Our patient here had a mean gradient of 92. It's actually the highest that I've ever seen of a mean gradient. Severe aortic stenosis is a mean gradient of greater than 40. So this is really high. Most patients have a mean gradient between 40 and 50. So 90 is quite high. You can imagine very symptomatic. After the TAVR valve, the mean gradient is decreased to 7.5. So dramatic benefit. And you can think about it. Imagine the amount of stress that the left ventricle is feeling. So if the patient has a systolic blood pressure of 100 and with a map of, let's say, 65, and the mean gradient across that valve is 90, their left ventricle is essentially experiencing a mean gradient of 140, 150 millimeters of mercury. So it's a lot of stress of the heart, and no wonder why these patients are so symptomatic and have heart failure. So a little bit about the data supporting the use of these valves in patients. This is one of the trials that has been quoted the most. It's part of the Partner 1 trial. And what it did is it looked at patients and it randomized them into two different categories. It took all patients who had severe aortic stenosis and it classified them, are they inoperable or high risk? This is based on a heart team approach that decides, are they inoperable or high risk? If they were inoperable, they were randomized to either a TAVR or medical therapy. And this is the one that showed that you did medical therapy, many of them, 50% died within the first year. And then I'll share some data showing what happens if they have the transfemoral TAVR. It essentially reduces your mortality by about 40%. Then the high-risk population are those patients that could have surgery, but they would be considered high surgical risk candidates. And I'm making distinctions between surgical AVR, SAVR, and transcatheter AVR, TAVR. Surgical AVR being the traditional sternotomy, TAVR being through the groin, through the apex, or one of these other ways that I mentioned. When you look at these patients, 700 patients, they will be randomized to a transfemoral or transapical approach, and then you randomize them to either SAVR or TAVR, okay? This is completely randomized, flip a coin, right? Then we follow them for 5 years. This is what it showed. If you look at all the patients that had TAVR versus SAVR, no change, no statistical significant difference in their mortality, right? This includes all access sites. So at least we know that it's no worse than surgical AVR in this high-risk population. Strokes, no difference in strokes as well, coming out to 5 years. Valve durability. What this shows is the mean gradient before and the mean gradient after the valve was placed. You see the mean gradient of 43 drops dramatically after the valve is placed, whether it's surgical or percutaneous, and it stays low. What that's telling us that there's no early deterioration of the valve. And for the data we have here for at least the next 5 years, the surgical valves and the transcatheter valves, they seem to be just as durable. Median survival, maybe slightly higher with TAVR than with SAVR, but no significant difference really between the two. NYHA class, no difference. So the recurrent theme here is that in this study, SAVR versus TAVR, about the same. Okay? The big differences are here. Major vascular complications, 11% in the TAVR group versus 4% in the SAVR. Why? Because you're doing it through a transfemoral approach. So you're going to have more bleeding, especially if you don't know how to manage the groins well. But that's something that we can take care of. Major bleeding complications, just in general, they were actually higher with the surgical group than with the TAVR group. Why? Because these patients could have bleeding from the sternotomy. So it makes sense that this would happen. This didn't translate to higher mortality rates necessarily as an overall population. One also a significant difference is with the early generation TAVR valves. They used to have a significant amount of aortic insufficiency. That's something we don't see as much anymore with the new generation valves. It was clear that if you had some AI after your TAVR, your mortality was actually slightly higher. So that's why we developed this new technology that could decrease the amount of AI. All right. Then we took a look at this population, because as I mentioned to you, right, I said that if you do a TAVR through a transfemoral approach, your risk of dying is in having complications is less than if you have it done through a transapical approach. So this led to this analysis. It's a subgroup analysis, so it doesn't prove anything necessarily, but it gives you sort of food for thought. That if you took patients that didn't have much aortic insufficiency and had a transfemoral approach, which is essentially 95% of the TAVRs we do nowadays, and you compare them to the SAVR group, you notice there was actually a mortality benefit relative to SAVR. So when I have a patient who is high risk, I can tell them that the data shows that a TAVR versus a SAVR, no significant difference in mortality or stroke. But if we can do a transfemoral TAVR in you, and we can have minimal aortic insufficiency afterwards, which, like I said, is the case in about 95% of our cases, there will actually be a mortality benefit, even in the high-risk group. All right, so let me change gears, and now we're going to talk about a different type of valve called Evolute R and Core valve. Core valve is the first generation, Evolute is the second generation. The difference with this valve is that it's a self-expanding valve. The first valve that I showed you was balloon expandable. This is self-expanding, so it has slightly different properties, but it's been studied very rigorously. This valve is limited to implantation from a transfemoral, left subclavian, or a transaortic position. You cannot do a transapical with it. There's not as much data on this valve, but the 3-year data, the way this trial was done, again, it was randomized patients in a 50-50 to surgery versus TAVR using this different valve. And what it showed actually, that it had a lower mortality and stroke rate versus surgical AVR in this high-risk population. Stroke rates were also lower with the TAVR group than with the surgical group. And mortality was also lower, but not statistically significant than the surgical group. The valve's mean gradients remain low. That means that the valve was working just fine after 3 years. And all of this data combined led to this recommendation by the guidelines that TAVR is a reasonable alternative to surgical AVR in patients who meet an indication for AVR and who have a high surgical risk. This, guidelines are always a bit delayed, but it was good data, right? It's a 2A, level evidence B, so pretty good recommendation. Now we actually have although it's not a guideline recommendation, we are now approved to do TAVRs in patients who are considered intermediate risk for surgical AVR because the data has been so strong. And I'm going to show you a little bit about that. So what's the data for that? So looking at, this is now the second generation valve, the SAPIEN XT. This was used to predominantly support the use of intermediate risk patients. Same thing, they basically took a look at 2,000 patients who had an STS score of greater than 4% or were deemed to be intermediate, and you just randomized them. If there was a transfemoral or an alternative access route to either TAVR or SAVR, all right? And then we just followed these. What did we find? We found that all-cause mortality and disabling stroke, no difference between the two groups if you combined everyone. And again, we saw the same thing. If you did a transfemoral approach, it seemed to have the primary endpoint was better for the TAVR group. If you did a transthoracic, meaning transapical or transaortic, they tended to do worse relative to surgery. So we looked at the group, the randomized group, of all transfemorals, and we just saw all-cause mortality or disabling stroke. And in this intermediate group, it showed a statistically significant benefit of doing TAVR over SAVR. So this is randomized data supporting the initial hypothesis that a transfemoral TAVR would have a mortality and a stroke benefit as a combined endpoint relative to SAVR. You had a question?
Are these the same valve put in either surgically or with the TAVR? Different valves?
Different valves altogether.
And so you're comparing valves and procedures then?
Yeah, exactly. Right. So the TAVR valves are valves that are, they can be expanded, so they're crimped. The surgical valves are fixed, that don't need crimping. So you're right, you're comparing the type of valve as well as the procedure itself.
Have they used the TAVR valves in the surgical procedure?
So not quite, but they've done actually there's a trial that Hoag was a part of where they used a hybrid of the two. It was a valve that was placed, that was balloon expandable, and then after they deployed it, had to be sutured with 3 sutures. So it was a little bit of a hybrid. Okay. So here you look at some of the data. The main things that were evident were here. Vascular complications still higher with the TAVR group than with the surgical group. Life-threatening disabling bleeding much higher with the surgical group than the TAVR group. Renal insufficiency higher with the SAVR than the TAVR. And new AFib much higher with the surgery than the TAVR. So other than the vascular issues, everything else benefited TAVR. Paravalvular leak, still. TAVR, you see that there's moderate paravalvular leak, mild and moderate. With surgery, it was pretty much all none or trace. So still, the surgical valves seem to do a better job with the aortic insufficiency than the TAVR valves, but at this point, it didn't seem to affect mortality as it had before, not to the same extent. It shows that if you're able to have mild or less aortic insufficiency, there's no difference in mortality. It's only when you leave patients with moderate or severe aortic insufficiency that it's a problem. We've done at least 150 SAPIEN 3 valves now, and I could tell you that not one of them has given us moderate aortic insufficiency. The technology is so good that it doesn't happen anymore. So this is the valve that we're using now. This is the 3rd generation valve, SAPIEN 3. And here it just shows you that over time, as you've gone from the 1st generation valve, 2nd generation valve, and 3rd generation valve, the all-cause mortality at 30 days has just been decreasing. And now it's at 1.6%. So pretty dramatic. So the big question is, the first trial I told you about was being used the 1st generation. The next trial I showed you used a 2nd generation valve. What about the 3rd generation valve? Well, there was no trials looking at the 3rd generation valves. There was a registry. And they did a propensity scored analysis, where basically what they did is, this is not randomized data, but what they did is they compared a surgical AVR with the SAPIEN 3. So really trying to compare the newest valves that are available out there with the surgical valves in intermediate risk patients. And using this propensity scoring analysis, what we determined was this, that if you use the SAPIEN 3 valve, less mortality, less stroke. If let's say you had moderate aortic insufficiency, then surgery was better. So if you can do a TAVR through a transfemoral approach and have a low aortic insufficiency, you'll have stroke and mortality benefits. That's the bottom line. How do we accomplish these efforts? It actually takes, it's a team effort to making sure that we deploy the valve that's the right size and doing it correctly. But like I said, here at Hoag, we have a lot of support, so we actually do a very good job of that. And so this was the data when you did the propensity score analysis showing you. So for the SAPIEN valve, 10.8% of all-cause mortality or stroke at 1 year versus surgery was 18.8%. It's a statistically significant difference. And for all-cause mortality, 7.4% for TAVR, 13% for surgery. Again, not randomized data, it's a propensity scored analysis, but it does give you pretty good perspective, and it just helps to underscore the fact that that mortality and stroke is less with TAVR than with SAVR if you use these valves. Same thing here. Same as before. Vascular complications, at this point slightly higher with TAVR than with surgery, more renal failure with surgery, more disabling bleeding with surgery, and more AFib with surgery. So based on this information, the conclusion was that Partner 2A, so these trials, provide strong evidence that an intermediate risk patient with severe aortic stenosis using a SAPIEN 3 compared to surgery improves clinical outcomes and is the preferred therapy. This is not a guideline. This is a recommendation that's made by the authors of the paper, right? So obviously very biased, but it's still you can't reject the data. So what happens now? Now we're looking at lower risk patients. At the low risk patients, those I was talking to you about. These are 3 different trials that are looking at patients who are low surgical risk. We're involved in this trial here. This is Partner 3, where we're taking patients with severe symptomatic aortic stenosis that would otherwise undergo a low-risk surgical AVR. These patients are being randomized in a 1-to-1 fashion to TAVR versus SAVR. Okay, so we're enrolling for that. So basically, TAVR is now available for any patient. Big question is, how long do these valves last? Everyone wonders this, right? So let's look at some of the data. We can do a valve-in-valve. What that basically means is if a patient comes in with a bioprosthetic valve, we can actually put a TAVR valve inside of that valve. It's called the valve-in-valve. And we were following, well, how well do these patients do afterwards? But it was actually a really good use of data to determine when did these initial surgical bioprosthetic valves get placed and how long did they last? And that's what this data shows. Almost 1,600 patients that were followed in this valve-in-valve registry. And it noted that they were all over the place. The surgical valves lasted maybe less than a year or could last up to 30 years, according to records. But on average, as you can see here, they seem to sort of cluster between 8 to 12 years, kind of corroborating this notion that bioprosthetic valves, surgical valves, probably last about 10 years. That was the thought. There are 2 main groups that have been looking at TAVR valves since early in the 2000s. This is data from one of the groups in Vancouver from John Webb's lab, where they looked at all the patients who had a valve implanted between 2005 and 2011. These were all balloon expandable valves, and they excluded any valve that deteriorated immediately thereafter, thought to be because of an implantation error. So, and this was the breakdown. This is the prototype valve, first generation, and second generation valve. And they followed these patients for 5 years. And they noticed that there was a 1.9% rate of valve deterioration after this time. So this tells us these valves lasting for from between 6 to 11 years had a very low rate of valve deterioration. And the valve deterioration was defined as severe aortic stenosis or severe aortic insufficiency, just like we would define it for a native valve. This other group in France has been doing TAVR since 2002. This is actually the lab from the Dr. Alain Cribier, who came up with the first TAVR valve. And they've been doing valves since 2002. They looked at 240 patients. There was no patient that developed severe aortic stenosis, but there was one patient that developed severe aortic insufficiency. All they did was they did a valve-in-valve, and the patient was treated just fine. All right, so that's it for the transcatheter aortic valve replacement portion. Any questions about that?
How do you get the valve out?
So you don't take it out. You leave it there. Inside. Yeah, you put it inside. There's certain limitations, but generally you can do that. Anything else? Yes.
If you do a valve-in-valve, then is the second valve, because they have to be smaller than the first valve?
Not necessarily. So if you do, there aren't many TAVR valves and valves. It's usually a surgical bioprosthetic valve and then another valve inside. But I can tell you that if we do a TAVR valve and valve, likely it's going to be the same size valve. Yes?
In these mechanical valves, how long, in what space of time, can a patient who's taken off Coumadin develop an embolus?
So TAVR valves and valves can only be done in bioprosthetics, not mechanical valves. Only in bioprosthetics. But to your point, as far as when the when they develop a thrombus after you take them off Coumadin. It all depends on the type of valve and its position, whether it's aortic or mitral. It depends. So let's move over to so the next piece is this is the mitral clip. Now we're changing gears from looking at the aortic valve to the mitral valve. So the mitral clip is intended for mitral valve repair. So this is the device that is used. Any way you can lower the lights in the front? I don't know if it's possible. So this is the device. This is the delivery device that is used to deploy this little piece right here. That's the mitral clip. That's what ends up being left in the body. It's based on this notion of the Alfieri stitch, where you actually stitch together the anterior and posterior leaflets and creating a double orifice mitral valve. This is an animation showing you what it looks like. So for orientation, this is the aortic valve, this is the mitral valve. This device has gone through a venous route, through the septum, and now we're in the left atrium. You open up the device and you position it. This is the anterior and this is the posterior mitral leaflet. You orient it in a perpendicular and an orthogonal in 3 dimensions over the valve. The blue here is showing you the MR, and then you advance it. So once you advance it, you clip it, and if you like where it is, you can leave it there. If you don't like where it is because there's still a lot of aortic insufficiency, you release it, you move it into a different position, you come back again, you grasp it, you close it, and that's it. And then you release it. You just unscrew it, and you're left with a double orifice valve. So who are the patients that are eligible for this? So this is a technology that is used in patients who have a predominantly degenerative form of mitral regurgitation, and it's severe and symptomatic. What does degenerative mean? Basically, there's a problem with the mitral valve leaflets themselves. You can have a functional mitral regurgitation, also known as secondary mitral regurgitation, because the annulus is dilated or because the patient has a dilated left ventricle and the papillary muscle is being pulled back. Right now, it's not indicated for that. It's mostly for a primary degenerative disease. What does it do? We know that using the mitral clip reduces the amount of MR. So this is an example of a pre-mitral clip patient, has 4+ or 3+ MR. A year afterwards, they're reduced to a 1+ or 2+. So we don't get rid of the MR, we reduce it as much as we can, and typically by about 2 to 3 points. It reduces hospitalizations dramatically as well. So there's a 73% reduction in hospitalizations, and their NYHA class improves dramatically from a class 4 and a class 3 down to predominantly a class 1 and a class 2. So when a patient comes in with severe MR that I'm going to do a mitral clip on, what I ask them is, how symptomatic are they, and have they been hospitalized? Because I know that all I can do is help improve their symptoms and help keep them out of the hospital. There's really no mortality benefit that's been shown with the mitral clip, but it does improve their quality of life, which for many of these patients is probably the most important thing. There is some improvement in LV remodeling, but it's not very significant. So this is an example of a patient who has severe MR. When you look at this transthoracic echo, you're not really all impressed by it. But what happens is you see there's a fair amount of aliasing. Keep in mind, this patient is presenting with recurrent heart failure exacerbations, heart failure hospitalization. So you have to start thinking there's something else going on. So the patient was referred to me, took a look at it, and we saw there was a lot of aliasing here. And it seemed to be maybe a jet that was being directed anteriorly. And sure enough, this is the transesophageal echo. It shows that there's a flail of the posterior leaflet, causing this eccentric jet that was giving you that aliasing. So this patient has severe symptomatic mitral regurgitation. You look at the pulmonary veins, you use the EKG to guide you, and it's predominantly D-dominant, suggesting high left atrial pressures. And this is what it looks like after we deployed the first mitral clip right here. This is the device that was used to deploy the mitral clip. And you can see there's very little MR. And now the veins are predominantly S-dominant. You look at the left, this is the left atrial pressure. Before the mitral clip, mean was 37, afterwards it's 27. So a dramatic drop in the left atrial pressure. And this is why they feel better. And they feel better actually really quickly, because all of a sudden their PA pressures their left atrial pressures drop. So again, let's see some data showing that this is actually of any benefit. So this is one of the more salient trials called Everest 2. This looked at a slightly different population, but it helped to prove the point of how effective the mitral clip was. It looked at patients who had both degenerative and functional mitral regurgitation, and it compared, and had severe mitral regurgitation, and it compared the mitral clip to surgery. Which one is better, or are they just as good? All right, so what we found out that the survival was the same for both. There wasn't a mortality benefit to using one versus the other. This is freedom from mitral valve surgery or reoperation. What we found out was that there was a bit of a learning curve when using the mitral clip. Initially, when people were put in the mitral clip, they weren't doing a very good job requiring them to do a mitral valve repair or replacement afterwards. If the mitral clip is placed correctly, what you actually see is that these curves are parallel to each other. So this just reflects that learning curve aspect of it. But basically, if you do a good job and you place the mitral valve, the mitral clip in the right spot, there's no higher incidence of reoperation than if you had a surgical MV repair or replacement. This is very important because this is where a lot of people sort of don't have difficulty with this concept of the mitral clip. So this tells you how much MR there is at the beginning. So before you do the mitral clip or before you do a surgical mitral valve repair or replacement. There's 3+ and 4+ MR. So severe mitral regurgitation in these patients. At 1 year with the mitral clip, the MR has reduced from 3+ and 4+ down to 1+ and 2+. With surgery, it's almost gone, right? 0+, 1+, or 2+. So clearly with surgery, you get a much better reduction in the amount of MR than you'd get with mitral clip. No question about that. And this persists. At 5 years, there's really no difference in these two, right? So it persists. But this is the key. The key is that the symptoms are the same. So it's not that we need to reduce the MR to trace or none. We need to reduce it enough so that they will feel better. So we know patients can tolerate mild to moderate MR and do just fine. And that's what this is showing us, is that even though there's still more MR in the mitral clip group than the surgical group, they basically have the same degree of NYHA class. So they benefit from it. And this benefit persists over 5 years. So when I do a mitral clip and you see there's still some residual MR, it's not a failure. I know when you do a surgical mitral valve repair, you want no MR. And you get concerned if there's any. Sometimes you even go back on pump to fix it. With a mitral clip, you don't need to do that. You can leave a little bit of MR because we know that it's not going to make a difference in their NYHA class. They're not going to feel that much better if you reduce their MR from a 1+ to a 0. So what's the initial experience using the mitral clip? So this is real. This is the registry data. How safe is this procedure? So in-hospital mortality for the mitral clip, 2.3%. And remind you, these are patients who are considered to be very high surgical risk patients to begin with. Open heart surgery, so how often were these patients that had the mitral clip done converted to an open procedure? 0.7% of the time. At Hoag, we did 25 mitral clips last year. So in 2016, we did 25 mitral clips. That means that if it's 0.7%, we'd have to do about 120 to 130 mitral clips a year to see one conversion of the mitral clip to a surgical repair. So it would take us basically 5 years to have to do a surgical mitral valve repair in these mitral clip patients. So very safe procedure, very safe. MR reduction, we saw significant reduction in the MR. So this is 4+ and 3+. Predominantly, it's going to be 1+ and 2+. So this is another example of a mitral clip that was done. Here you have the anterior, so the left ventricle, aortic valve is right here, the left atrium. This is the right ventricle. You see here there's a flailed posterior leaflet, anterior leaflet. They're over here. This is called the bicommissural view that shows you, this is the anterior leaflet is right here. This is A2. This is P3. This is P1. It's just nomenclature. And this, we use all these views to help guide placement of the clip. This is a really cool image of a 3D image, and it shows you. So just to kind of orient you, so this is we're actually inside the left atrium. This is the anterior leaflet. This is the posterior leaflet right here. And what it shows us is that there's a flail right here, right in the middle, A2, P2. So that's what we're going to try to capture. Look at the veins, maybe slightly S-dominant or blunted. We always check for the mean gradient to make sure that it's not high. If it's high, we can't do the mitral clip, otherwise we're going to cause mitral stenosis. So here we go. We place the first clip. Pretty good reduction in the amount of MR. You see the clip here in 3D, pretty good reduction, but this is medial, this is lateral. Laterally, you still see a little bit of a flail there. The mean gradient is now going up to 5, which is okay, but we don't want it to go much higher than 5. Now the veins are clearly more S-dominant than they were before. And this is an image of what it looks like. You can see this poor patient is bionic. But you see the clip is deployed right here. It's kind of moving around. Over time, you get a sense of what it means for the clip to be stable or not. If the clip is moving this much, I am concerned that it could dislodge. So I decided to put another clip next to it to stabilize it. And here's a picture showing it. So again, you see here this posterior flail is still a little bit there. We position next to it, we deploy it. I mean, this is trace MR. And interestingly, the mean gradient came down to 4. And it can happen. Why? Because the MR can artificially increase the mean gradient. And we check to make sure the mean gradient isn't too high before we deploy it. And remember, we put the clip in there, we close it, and if we don't think it's in the right position, we can move it or take it out of the body completely. That's not a problem. And so here's what it looks like, the double orifice. So this is one orifice, this is another. Again, this is anterior, this is posterior. The clips are right in the middle. And now we deploy the second clip here. And you see when we release, how they're moving in unison. They're not as mobile as before. It's more secure, so we're really happy with that result. And this is what it looks like with transthoracic echo. I mean, people sometimes get concerned, oh my gosh, are you occluding flow completely? No, it's just the transthoracic is looking at the A2P2 level, which is looking at the clips. But there's a double orifice here. And we showed in different views, but excellent result, right? Okay. Just briefly, what are devices that are being generated to be also, again, percutaneous ways of being able to fix the mitral valve? Thoughts about maybe putting a ring around the annulus and being able to bring the annulus together. And all of this is being done percutaneously. And the next real step in structural heart disease you're going to be seeing in the next 3 to 5 years is this concept of a mitral valve replacement. No longer repair, but replacement. It's going to be done percutaneously. There are 3 main companies that are working on that right now. So just watch out for that. So now the last piece is going to be the Watchman. But any questions about the mitral clip? Yes?
What's the nature of the surgical fix for the mitral regurgitation that you're comparing them to?
It was not the Alfieri stitch. It was whatever they felt it would be appropriate, whether it was a repair or replacement. I'm sorry?
Could be valve replacement?
Yes, it could be a valve replacement.
Do you get a mitral stenosis from your clips at all?
So we can. It depends also how you define it, right? So if you look at the classic definition of mitral stenosis being at 5 and 10 millimeters of mercury as the cutoffs, we are okay as long as the mean gradient is less than 5. If it's greater than 5, we don't like that. So we will leave them with mild mitral stenosis, but not moderate, and definitely not severe. And what we'll do is we will, before we release the clip, we'll assess the mitral valve, the mean mitral valve gradient. And if it's greater than 5, we actually either move the clip or take it out completely. We won't deploy it.
And how about over time? Do you see any changes in that pressure?
It can actually, and sometimes it depends. We know that mitral stenosis is dependent on blood pressure and heart rate. So it's usually more evident with heart rate. So if a patient becomes tachycardic, you can develop mitral, what looks like pseudo-mitral stenosis. So in those patients, we have to brady them down to the 60s in order to help maintain an adequate mean gradient. But it won't happen because of scarring or anything like that. It really is just more about the hemodynamics.
So 5 or 10 years out, there's no change?
You know, I don't know that exact data for mitral stenosis specifically, so I don't know. But I do know that at 5 years, there was no significant change in symptoms. But I don't know about the specific numbers. Okay, so the Watchman. So the Watchman it's a different device. This device is used to treat patients with atrial fibrillation. It kind of looks like a jellyfish, but the idea behind it is that it's a left atrial appendage closure therapy that is used in order to protect patients from stroke who have non-valvular AFib and who have a difficulty taking anticoagulants. And it's considered to be an alternative to anticoagulation. So we know atrial fibrillation is a very high prevalent disease, and we also know that about 90% of strokes in patients who have atrial fibrillation arise from the left atrial appendage. We also know that as we get older, as the population ages, more patients will have atrial fibrillation. And we know about this CHA2DS2-VASc score that gives us a sense of the risk versus the benefit of placing a patient with atrial fibrillation on anticoagulation. Anyone who has a CHA2DS2-VASc score of 2 or greater is recommended to be on an anticoagulant. So when we think about the watchman, you have to think about the patient as a whole, obviously, right? So you think about AFib, you diagnose AFib. There's 2 different ways of addressing it. One of them is, do you fix the atrial fibrillation? And there's different ways in which we can try to fix the atrial fibrillation. But a whole different question is, how do you manage the strokes that are related to having atrial fibrillation? We know that if you have a patient who has AFib to go in an AFib ablation and are now in sinus, they stay on anticoagulants because they can develop AFib for short periods of time and have a stroke. We don't know how long they need to be anticoagulants, but we know that. So having AFib, you have to start thinking about it, addressing the stroke risks and addressing the rhythm problems, okay? So this side here is about managing the rhythm. You can ablate, so you can do an AFib ablation, you can do AV nodal ablation and pace the patient, or you can use antiarrhythmics or cardioversions. But that doesn't do anything about the stroke risk related to it. This is a separate issue altogether. And the way you manage it is you can use Warfarin, so you can use one of the novel oral anticoagulants, or the intervention component that I'm going to focus on mostly. All right. When you look at Warfarin, you know that there's a therapeutic range, right, between 2 and 3. In patients who have strokes, typically they were subtherapeutic. In people who have bleeding episodes, they're usually super therapeutic. And we know that about 50% of the patients are actually therapeutic. The other 50% are either supra-therapeutic or sub-therapeutic. So they're not being protected well. And that's because Coumadin is a very difficult drug to take. So the thought is, okay, let's put them on the NOACs. The problem with the NOACs is that there's still a very high rate of drug discontinuation, whether it's because of bleeding or because of inconvenience. And this data here is from the trials. So the patients have access to the medications. It doesn't take into account that these medications aren't generic and it can be expensive. So there's a high rate of patients who have atrial fibrillation who are not being appropriately anticoagulated. We know that for sure. So initially, the thought was, let's just cut out the left atrial appendage. And that was being done surgically. There isn't a whole lot of data supporting the use of surgery. More recently, there is a device called the Mitral Clip that's being done in order to remove the left atrial appendage. There's some data that's being collected for the Mitral Clip, but not nearly as much as it has been for the Watchman device. These are the 5 devices that we think about when we're thinking about left atrial appendage exclusion therapies. The first one is Plato. This was one of the very first ones that was used. It's basically a plug that goes into the left atrial appendage, so any clots that form in the appendage can't exit. The Watchman, as we've talked about. Next one is called the Amplatzer cardiac plug. It's not being studied yet, but it soon will be. It also goes into the appendage. And these here are both surgical approaches. This is the Atrial Clip, which basically cuts it out. You can do it at the time that you're doing any sort of a sternotomy, or you can do it completely independently with a mini thoracotomy. And then you have the surgical ligation. It's called the lariat. It's basically a suture that's placed around the neck of the appendage, and it cinches the appendage, literally like lassoing it. It's done through a percutaneous, but also you have to get access into the pericardial space. But of all of these, the only ones that are approved to be used is the Watchman and the Atrial Clip. This used to be approved, but not anymore. And the only one that's been studied rigorously is the Watchman device. It has 10 years of data backing it up. So the Watchman device comes in 5 different sizes. It's made out of a self-expanding material called nitinol. Has little teeth here that help hold it in place. And there's a mesh here that's used to help endothelialize when it's placed. It goes into the left atrial appendage right here through a venous and a transeptal approach, like that. Patients are done in the cath lab, in the hybrid room. It's done with general anesthesia because you need transesophageal echo to be able to guide you. And the procedure takes about an hour, and it's a one-day stay in the hospital. You stay overnight, you go home the next day. Who's eligible for these patients? So these patients have to have a CHAD score of greater than 2 or a CHADS VAS score of 3 or greater. They need to be able to take a short duration of Coumadin, that's 45 days, but are not deemed to be suitable long-term candidates, and they can't have any contraindication to this transeptal approach. So this is an example of a case that we did. So initially with all my cases, what I'll do is I'll get a baseline transesophageal echo to get a sense of the appendage, the size, to make sure that I'm going to be able to fit one of these 5 devices. You take it at 0 degrees, 45 degrees, 90 degrees, and 135 degrees. So this is the imaging just to kind of orient you. So this is the transesophageal probe. These are pacing wires that the patient has for other reasons. This is the sheath that's going to be used in order to deploy the device. This is the appendage. That's what it looks like. This is the pigtail that helps me securely place a sheath. Now this is the device that's coming out. I'm unsheathing it slowly. As I come out, I'm making sure I'm in the right spot. Everything is safe. And then I deploy it, and it looks like that. Now I inject, and I see that there's a little bit of flow going through it, but it's going through the mesh, which I expect, but there's no flow around it. I like where it is. I release it, and that's it. And you just leave it like that. And on echo, this is what it looks like. Looks like a little mushroom. So this is the aortic valves, left atrium. This is the appendage. And what will happen is all this will thrombose, but it can't exit because the mesh is preventing it. It's a 3D picture of it. This is another case that I did. Here, you see there's a lobe here that's being filled with a contrast that I wasn't able to cover. If I was to stop here, this would form a clot and give the patient a stroke. So what I did is I pulled back on it a little bit, and then check, and now it's been pulled back, and now it's covering up that area. So it's in a secure position. I release it, and I'm happy with the result. All right, what does it look like? So at 30 days, it's partially endothelialized. At 45 days, it's pretty much completely endothelialized. That's why you have to keep them on Coumadin for that 45 days, as I mentioned, is so that you leave an opportunity for the device to endothelialize. And this is this is a post-mortem for a different reason. The patient had a Watchman placed but died for other reasons. And this is at 9 months. You can see it's completely endothelialized. So 6,000 patients studied in 2 trials and 2 registries ever since 2005, so it's been around for a long time. And as far as how successful implanting it over time, we found that there's a very high success rate. And here's important as well. There are times in which you may not be able to stop the warfarin at 45 days. You may have to continue it for longer, but really more than 99% of patients can get off warfarin after a year. So this was the most, I think, important part of the different trials, specifically Protect IF. It actually showed a mortality benefit to using the Watchman device. The reason being is that when these patients are eventually taken off Coumadin, like I said, these are patients who have an indication who are not good candidates for a long-term anticoagulation. These are patients who are falling, bleeding, having GI bleeds, have high-risk jobs, those kinds of things. A lot of these patients were dying from hemorrhagic events. So when you compared the cardiovascular or unexplained death in the warfarin versus the Watchman group, it was lower in the Watchman than the warfarin group. So significant risk reduction in death at 5 years. And this kind of shows you what is happening. It's so free of a major bleeding event. Basically shows you initially the warfarin group here has a very low risk of bleeding relative to the Watchman group initially. Why? Because in the first period of time, you get bleeding from the procedure itself, and then you also have to be on warfarin and aspirin. Once you're able to then switch over to just being on aspirin alone, which occurs at a 6-month period, the rates of bleeding for the Watchman device decreased the free of major bleeding event is much, much lower than it is for the Warfarin. It just tells you, if you're on Warfarin, you're more likely to bleed, and if you bleed, we know that's related to mortality. So this mortality benefit of the Watchman device or Warfarin is driven by decreased bleeding with the Watchman device. It's an example of a case that we did where I wasn't able to cross a septum, so there's a balloon here that's used in order to balloon the septum to make room. You can kind of see a little bit of a waist there to put the Watchman device. I go in and then I take a look and it doesn't seem like it's in the right spot. This seems to be maybe there's a little bit of contrast up here. On echo I confirm it, and sure enough there's this large lobe up here that I wasn't seeing. I deploy the Watchman device. I like how it looks. Inject. It looks good. It's covering everything really well. Release it. It's doing just fine. This is how it looks like afterwards on echo. So who's a good candidate for the Watchman device? Major bleeding while taking oral anticoagulants, inability to the stable INR, inability to comply with regular INR monitoring, or if you have a high-risk job or some sort of a lifestyle that is high risk that makes you more prone to bleeding. Who's not a good candidate? Someone who needs to be on warfarin for other reasons. History of pulmonary embolisms, they have a mechanical valve. They're going to be on warfarin anyway, so why would you do this? A patient who's very sick to begin with and shouldn't have any more procedures done, or if there's a reason why the transeptal puncture cannot be done. Soon enough, there's a trial called ASAP-2 that's looking at possibly placing patients on, instead of warfarin after the device is implanted, on dual antiplatelet therapy. So 3 months of dual antiplatelet therapy, and then that would be aspirin and Plavix, and then 9 months of aspirin. All right, so in summary, what we talked about then, the TAVR. So TAVR is now indicated in inoperable and high-risk patients and intermediate-risk patients. Now we're enrolling in the low-risk Partner 3 trial. Mitral Clip, it improves the symptoms as well as reduces hospitalizations in patients with severe MR. And the Watchman is an excellent alternative to oral anticoagulants. That's it. Thank you. So any questions?